to yet another episode of the Core Consult RX podcast. Joining me as always, Cole. How's it going, man?
Doing good, Mike. How about you?
Can't complain. Never helps when I do, so.
Anybody sick, or y'all just doing good?
Of course. Of course. Yeah, both kids have colds, so they've been taking turns every hour on the hour screaming and waking up in the middle of the night, so it's been ideal.
Yeah.
How about yours?
Normal week. We're actually doing okay. Trying to keep them healthy for Christmas, but that probably won't work, so we'll see.
Yeah, I'm hoping they get it all out of their system, now so that they're not sick for Christmas, but with our luck, it'll be, Jen and I will both get colds going into Christmas.
Yeah.
But we'll see how it goes. Either way, it'll be all right. So tonight we are going to be covering a topic that we had done previously for Free CE. So this will be an accredited episode, but this is kind of off the wall. I don't want to say off the wall, but kind of a more obscure topic than we typically do. And we had done it previously, and since the continuing education accreditation piece had expired, we figured we would kind of run through it again and provide a few updates that have come out since the previous time we did this topic. But we're going to be covering food allergies, and then towards the end we'll also touch on celiac disease as well. But again, not a super typical topic for us, so it'll be a little bit more background information, pathophysiology, that kind of thing, heavy than medication wise, but we'll touch on a couple meds and stuff at the end.
We're more than just med heads, we got more to us.
We're extremely versatile, and now we're covering a topic that we may or may not botch. We'll see. But you guys kind of know my spiel at this point, but for those of you who are Free CE members, make sure that you listen closely, because we will give you a password at some point during this episode. You take that password, go to freece.com, find this episode under their learning column, and then you can gain access with that password to the post-activity quiz. 10-question multiple choice. Get those right, or the majority of them right, and you will get 1 hour of continuing education credit, and it's good for pharmacists as well as nurses. And for those of you who still have not joined Free CE, definitely encourage you, as always, to check them out. And they got some cool stuff coming up for the new year, some live panel discussions, which Cole and I may or may not even be involved in hosting one of those. You never know. But you'll never know if you don't join.
Find out. That's right.
So you got to join, because it's imperative that you support us as we do a live show, and see how that goes. See if we ever get asked back again. But definitely
at least
lots
it's not
of
the first time.
Yeah. Not the first time, but it's been a minute, so we'll see how it goes. But definitely looking forward to that and some other upcoming things that they have going on in the new year, and lots of great learning opportunities. So definitely make sure that you check out their different membership tiers that they have, and take advantage of that. Get all your credits knocked out for your license re-up all in one spot. So it's nice. Thanks to them, as always, for continuing to work with us. And without further ado, Cole, do you want to kick things off with some food allergy background?
Yes, let's do it. So we're going to talk primarily about food allergies, but it is important to delineate between a food allergy and a food intolerance, because there's different in more than just verbiage, but in the mechanism behind it. So we'll highlight each, but our focus is going to be more on food allergies, which involve an immunogenic response. They're IgE-mediated food allergies, for example. Even tiny amounts of food can cause severe reactions. The food allergic reactions can be unpredictable. They have the potential to progress to something that's more serious or life-threatening if there's anaphylaxis involved, because it involves IgE in that sort of response. A food intolerance is more of a umbrella term for the difficulty in digesting or metabolizing a particular food. It's kind of a subset of all adverse food reactions, and is reported in a large portion of people, 15 to 20% of people. The amount of food directly relates to the severity of symptoms is one way to easily delineate between them. and the food causes similar symptoms with each exposure. It's kind of predictable and doesn't necessarily progress, and is typically not life-threatening.
Yeah, and there's some other, sort of subcategories, if you will, of intolerance. So to give you an example, like lactase deficiency, or more commonly known as lactose intolerance, basically presents as symptom-wise as bloating, abdominal cramping, flatulence, possibly diarrhea, and that happens after the consumption of lactose that is often in dairy products. There's also things like fructose malabsorption, or fructose intolerance. Fructose intolerance is going to, symptom-wise, look very similar: bloating, diarrhea, and that often happens after the ingestion of fruit or some kind of like a fruit-based sweetener, and that includes high fructose corn syrup. So that might not be too bad of a situation in that case, because it's not great for you. And then there's also things like aldehyde dehydrogenase deficiency, which is a deficiency in that specific enzyme, and patients will often present in flushing, specifically after alcohol is consumed, and it is statistically more prevalent in people of Asian descent.
There's a few others. Another enzyme deficiency, G6PD deficiency. That enzyme is glucose-6-phosphate dehydrogenase. It usually presents with hemolysis, usually in males, after the ingestion of fava beans, the most commonly type of consumed bean, red wine, legumes, blueberry, soy, tonic water, interestingly, for all those who just drink straight tonic water. Other medications, you likely recognize that from interactions with other medications as well. Also, intolerances to short-chain fermentable carbohydrates. Symptoms of that would be flatulence, abdominal pain, bloating, diarrhea, after foods containing FODMAPs, which you've probably heard of: fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Migraine headaches may be considered a manifestation of a food intolerance if it's triggered by certain foods in a specific patient. And foods with high biogenic amine content have been implicated. I'm trying to think of, I heard so many triggers from people when I worked with migraines a lot. And I'm trying to think of some, I worked with a technician once who, the smell of onions, I'm pretty sure it was like migraine immediately if anybody in the break room just decided to heat something up with onions. So that's an example, I guess.
Well, and there's some other fairly common triggers for migraine headache that are, from a statistical standpoint, would be dietary triggers, things like alcohol, chocolate, unfortunately for some people, aged cheeses, not as important as chocolate.
Not the young cheeses, just the old
Yeah,
ones.
no, the young cheeses are usually fine. But the MSG, they can be in certain foods, NutraSweet, caffeine, even in some instances, nuts, nitrates, or nitrites. And then, Cole, you mentioned FODMAPs, which we had talked about a little bit when we covered IBS in the past. But to give you some examples, Cole already went through the acronym, but some like oligosaccharides, that's like your wheat, barley, onion, artichokes, peas, legumes, things like that, lentils. Disaccharides would be more like your milk, ice cream, yogurt. Monosaccharides being like your fruits, or apples, pears, mangoes, cherries, and even high fructose corn syrup would kind of fall into that. And then polyols would be, again, things that contain like sorbitol, mannitol, xylitol. So again, pears, cherries, peaches, plums, watermelon, mushrooms, cauliflower, some other things, as well as artificial sweetened, chewing gum and things like that. So you'll hear certain people trying to kind of follow, paying attention to their FODMAPs, for IBS specifically, but there's also, other patients who just are intolerant of that in general.
A couple other reactions that aren't necessarily IgE-mediated allergic reactions would be mast cell activation, Patients with mast cell disorders may experience episodes of activation in the absence of an IgE-mediated food allergy. Some symptoms they could experience would be flushing, itching, diarrhea, abdominal cramping, usually after spicy or aged foods, as well as alcohol. Then there's sulfite sensitivity. It's a sensitivity to ingested sulfites that's believed to disproportionately affect patients with severe asthma who can experience wheezing in response to dietary sulfites.
And then, of course, we also have our non-immunological adverse food reactions. Primarily, we think of like gastrointestinal disorders. So, you could have reflux, carbohydrate malabsorption, which that's where lactase deficiency fall under. Irritable bowel syndrome can kind of fall into that as well. Things like yeast overgrowth syndrome or pancreatic insufficiency, which we would often see in patients with cystic fibrosis, gallbladder disease, things of that nature. There's also toxic reactions to certain foods. We oftentimes think of seafood. For example, like scombroid fish poisoning. You could have saxitoxin, which originates from shellfish. There's other food that can cause poisoning, and fungal toxins can be another source as well of a toxic reaction. So that would be kind of a separate category.
Right. And then there's foods that contain things that mimic or are very similar to pharmacologic agents that can cause reactions, like caffeine, which is a food item and also a drug technically. Certain teas and chocolate contain theobromine. Berries, wine, fish, sauerkraut contain histamine and histamine-like compounds. Tomatoes and plums contain tryptamine. Aged cheeses, pickled fish contain tyramine. Bananas and tomatoes contain serotonin. Didn't know that. Chocolate, phenylethylamine. Potatoes, glycosyl alkaloid, solanine, and then, of course, alcohol. And then there's flavorings and preservatives that can cause a response. There's one called sodium metabisulfite. I'm not familiar with that, but we're all probably familiar with monosodium glutamate, which would be MSG. You can also have neurologic reactions like auriculotemporal syndrome. People can have psychological responses to food, like food aversions, food phobias that can be brought about by intolerances to them, and then accidental contaminations of things that aren't supposed to be ingested, like a pesticide or something that was ingested, but maybe shouldn't have been, like an antibiotic if a patient has an allergy to a certain antibiotic.
Yeah, and when we think of from a population standpoint, estimations, say around 5% of adults have been affected by some kind of a true food allergy, and 8% of children. It's a little bit more common in children. There was a cross-sectional survey that looked at over 40,000 adults in the United States, and this was done 2015 to 2016, and basically the estimate of convincing food allergy was significantly higher at 10.8%, and that study with self-reported prevalence of twice that. So again, possibly people getting confused between a food allergy versus a sensitivity, but nonetheless higher than was previously kind of estimated. Food allergies can develop at any age. Even we oftentimes think of them happening sort of during childhood, or at least becoming present during childhood, but that's not always the case. There was a retrospective chart review showed approximately 15% of patients with an initial food allergy got that diagnosis in adulthood. So it's kind of interesting. And then the same study found that the age at first reaction peaked during the early 30s, although there was a wide range and an initial onset as late as 86 years of age. And of note, the authors mentioned that older age was associated with a higher risk for severe reactions to the allergy.
Right. So continuing on with actual food allergies, there's a number of clinical features that can be present if a patient ingests a food that they are allergic to, many of which you would anticipate with most allergic reactions, but some kind of unique. So itching, flushing, sweating, issues with the eyes like itching of the eyes, lacrimation, conjunctival injection, periorbital edema. In terms of respiratory system, sneezing, rhinorrhea, nasal congestion, some describe a metallic taste, a sense of choking or laryngeal edema, dyspnea, wheezing, cough, cyanosis with breathing difficulty. Cardiovascularly, there can be conduction disturbances, increased heart rate, decreased heart rate, arrhythmias, hypotension, and in most severe cases, cardiac arrest. You can have nausea and vomiting, abdominal cramping, bloating, diarrhea, but also neurologic symptoms as well, like dizziness or fainting, but also a sense of impending doom has been described, and even seizures in some instances.
And, the problem with, obviously, other than the overall concept, but one of the issues with, the severity itself of these IgE-mediated reactions is they can be variable, and they're not necessarily predictable based on previous, instances that they've occurred. And so an individual may develop hives on one occasion, and then later on develop life-threatening anaphylaxis the next time they ingest whatever it is that they're allergic to. So can be very, very serious, down to a sort of a minor issue that can be taken care of fairly quickly, like hives. There are actually some diagnostic criteria to actually get, the diagnosis of an anaphylaxis episode. It's basically an acute onset of an illness, minutes to several hours with involvement of the skin, mucosal tissue, or both. Generalized hives, pruritus, flushing, swollen lips, tongue, and they have to have at least one of the following. So they have to be respiratorily compromised, so dyspnea, wheeze, bronchospasm, stridor, hypoxemia, or reduced blood pressure, or associated symptoms of an end organ dysfunction. So syncope, incontinence, things like that. 2 or more of the following that occur rapidly after exposure to a likely allergen for that patient. So this is if it's minutes to several hours. Involvement of the skin, mucosal tissue, like we said, respiratory compromise, reduced blood pressure, or persistent gastrointestinal symptoms. So 2 or more of of those. And then reduced blood pressure after exposure of a known allergen for that patient within minutes to several hours would also classify as an anaphylactic reaction, and that can be low blood pressure, which is age-specific for like infants and children, or basically a greater than 30% decrease in their systolic blood pressure. And then for adults, it's a systolic blood pressure of less than 90 millimeters of mercury or greater, then a 30% decrease from that person's baseline. So a few different diagnosis criteria to actually have had experienced anaphylaxis, but definitely an experience that nobody wants to actually go through.
Right. And one of the other issues with allergies is even a tiny amount of food can cause a severe reaction, which is, like I mentioned before, different than an intolerance where it progressively gets worse as you ingest more food. A small amount of food can cause a problem. There's some factors that can make the allergic reaction more severe, like having concomitant asthma. Patients with asthma are at higher risk for food-induced anaphylaxis. If there's agents on board that increase intestinal permeability, like alcohol or aspirin. Certain other medications, like ACE inhibitors, beta blockers, they can impair the body's compensatory responses to hypotension, interfere with the actions of epinephrine if that's being given in the instance of a anaphylactic reaction. Exercise, exertion, stress, these can all compound it. If there's a concomitant illness, like a viral infection or really any other illness, or lack of sleep, all of these factors can cause or contribute to an allergic reaction being more severe.
And when it comes to the skin, definitely food allergies can cause an acute contact urticaria, which usually is going to develop only on skin that was in direct contact with the food. There's some other common allergens like raw meat, seafood, mustard, rice, beer, are among foods that basically have been implicated in this form of reaction. But other than urticaria, isolated, dermatitis by itself is not, or is a uncommon presentation of a true IgE mediated food allergy, especially in adults. In contrast, though, in children, especially those with severe eczema, atopic dermatitis, which we did an episode on somewhat recently, food allergies were found to exacerbate their eczema and cause other symptoms in up to 1/3 of subjects in some studies. So it does differentiate between its presentation in adults versus children.
Yeah. Okay. So let's move on to kind of talking about the specific types of food allergies and how they present and why they are what they are. So the first we'll talk about for the next few minutes is oral allergy syndrome. This is because it is the most common form of food allergy in adults, affecting up to 5% of the general population in some studies. It's also known as pollen food allergy syndrome, and we may just call it OAS, but oral allergy syndrome. It's generally a mild form of a food allergy. It's caused by contact of the mouth or throat with raw fruits and vegetables. Sometimes nuts can cause it as well. The most frequent symptoms are itchiness or mild swelling of the mouth, face, lip, or tongue, the throat, generally developing within minutes after eating raw fruits or vegetables. Cooked fruits and vegetables, interestingly, don't typically elicit the symptoms. And this is an important question to ask when you're evaluating the clinical history of the patient as to whether they were raw or cooked to kind of guide your diagnosis. Tree nuts and peanuts, raw and cooked, can also cause isolated oral symptoms, although these foods can also cause more serious systemic reactions as well, so it's appropriate to refer any nut reactions to a specialist to verify whether it's this or something more substantial.
Yeah, and OAS is an IgE-mediated, and it's considered a form of contact allergy that develops in patients that are basically sensitized to pollens. Most patients also report seasonal allergic rhinitis, as well as conjunctivitis. So some common examples would include like birch allergic patients may develop itching of the lips or mouth upon eating fresh apple, pear, cherry, celery, handling raw potato. Patients who are allergic to like ragweed may react to melons and bananas. Patients who have a mugwort allergy may react to raw celery. And OAS is caused by the presence of heat-labile proteins or profilins, as they're more accurately referred to as, within these foods that are cross-reactive with allergenic pollen proteins. And so that's where they kind of have that crossover.
Yeah. In the allergenic proteins, they cause mild symptoms on the mucosal surfaces of the mouth and the throat, but they're destroyed by the acid pH in the stomach or by heat when cooking. So that's why the cooked foods don't really cause this, and the reaction typically does not present with gastrointestinal symptoms or with systemic allergic symptoms, though a small minority of patients do seem to report systemic symptoms, less than 2%. If they do, it'd be appropriate to refer those patients to be evaluated by an allergist to make sure to see if there's any more serious forms of food allergy present, and they should be supplied with an auto-injector. Also, if you're unsure of what the diagnosis is, whether it's OAS or potentially something more serious, a referral is very reasonable from a primary care standpoint.
Yeah, and as far as management of OAS, really we're trying to encourage patients to just avoid the offending agent, whether, avoiding raw forms of fruits and vegetables that seem to be in question. Again, like Cole said, the cooked forms can be eaten as the patient tolerates. And if the patient does have sort of a straightforward example of OAS, then they don't necessarily have to be referred to an allergist. But again, to reiterate what Cole said, if there is any kind of question or any, uncertainty to the diagnosis, definitely in getting an allergist involved is the right move.
I'm sure we've talked about this before, but do you have any food allergies of any sort?
No,
or any allergies?
Not that I know of. No. Knock on wood.
Me
of course,
either. But
you never know. Maybe I just haven't tried. I don't eat a lot of, variety of foods. So who knows?
That's true.
Maybe I just haven't found mine yet.
I'm following the guidance of OAS by avoiding all fruits and vegetables.
That's good. That seems
and I
like
have
the right
for
move.
A long, long time.
That's good. That's definitely
maybe.
Yeah. If you take one thing away from this podcast, it's that.
But as I was kind of reminding myself about OAS, I feel like I know a lot of people who probably have that and don't realize it, and don't know that a cooked like it's like I can't eat these. Like they're like I can eat them, but I know it's gonna like cause my mouth and throat to be very irritated or whatever.
To swell. Yeah.
Yeah. But they have determined themselves that it's not anaphylactic
that apples
because
are delicious, they can eat it. And then they can move forward.
Right. But they probably have no idea that it could be cooked and probably would not cause that. So,
although
maybe
vegetables is one thing, but fruits, I don't know. But
baked apples with some cinnamon.
I'm not a big fan of like apple pie and stuff like that. So I don't think I would.
Neither am I. Like I said, I don't eat fruits or vegetables raw.
Right.
But I'm just saying that seems like something people like to eat.
That's true. Yeah, you're just trying to. Yeah, I get it. You're trying to include as many people as possible.
Yeah. Like kiwi, I hear it a lot with kiwi.
Yeah, kiwi's delicious.
Not that I eat any kiwi.
I'm a big kiwi guy.
Yeah.
All right.
Okay.
So oral allergy syndrome, but also very commonly seen seafood allergies. So most seafood allergic patients are allergic to either one or more finned fish or one or more shellfish, mollusks, kind of under that same umbrella. Only about 10% of patients with seafood allergies actually are reactive to foods in both groups. So it's usually one or the other. So, it's not all seafood in general, which I feel like a lot of times when patients say they're allergic to seafood, they do kind of encompass all types of seafood. But again, it might just be lack of education on the from the provider standpoint. So if a patient has an allergy to one specific type, so like shrimp, something like that, they can often safely continue to eat other types of seafood like fish and even possibly mollusks. A referral to an allergist can definitely be helpful in this situation to kind of determine which types are tolerated, and so the patient doesn't just have to avoid seafood for the rest of their life unless they just want to. Seafood allergies are, definitely very robust topic that if you check out like certain, like the up-to-date articles on this, they have like an entire section that's dedicated to seafood allergies because there's a lot that goes into it.
Yeah. One thing to note that you kind of hear thrown around sometimes is that seafood allergies are not related directly to a radio contrast allergy, which, we hear about with a lot of patients having radio contrast allergy. But individuals with allergic diseases in general, any of them, asthma, allergic rhinitis, atopic dermatitis, food allergies as a group are 3 times more likely than individuals without those conditions to have a severe adverse reaction to IV iodinated contrast media. Though there's no special precautions that are normally indicated prior to radiographic studies, aside from controlling asthma symptoms as well as possible beforehand. But most of the increased risk appears to be related to asthma, and there's no additional risk with a patient with a seafood allergy specifically, and no specific guidance related to it. But good to know that patients with allergic diseases are at much higher risk for contrast dye allergies.
Yeah, just at least, if nothing else, monitoring them more closely.
Yeah.
All right, so something that I think most of us would kind of automatically think in our minds when we think of food allergies, peanut and tree nut allergies seem to be at least in my anecdotal experience, the more commonly discussed food allergy that you hear. So peanuts and tree nuts are also, very commonly implicated as far as adults with food allergies. Although in most cases the nut allergy develops in childhood and kind of persisted into adulthood. Unlike the situation with seafood allergies, which is often presenting in adulthood. Because peanut and tree nut allergies can range from mild to quite severe, and can be very difficult in some cases to categorize. Definitely a good idea in that case, like Cole had mentioned earlier, to get an allergist involved to kind of make sure you're going through a very thorough evaluation and seeing exactly what types of nuts the patient may be allergic to, and to make sure it's not multiple types. But that's where an allergist definitely would need to step in when you start dealing with tree nuts or peanuts in general.
This really does seem to be so much more prevalent with like starting with the millennial age groups, doesn't it? I wonder about that. Like you go on a plane now, can't have nuts, but it's interesting. You go to other countries on a plane, they do have nuts. So it's like I wonder if it's an American thing.
Is that like a new? I feel like I've gotten peanuts on a plane before. No,
I guess it depends on the airline.
Yeah.
But whenever I go, no nut stuff. A lot of the packaging is like no nuts.
You
I
gotta
don't know
get
if
on
this was
Spirit
recommended.
Airlines more often. You get all the nut peanuts you want. They don't. They're like, here
Take
you go.
whatever you want.
Get to fly the plane if you want.
They have EpiPens. They're just $1,000.
Yeah.
And they will not inject you if you don't pay for it.
Yeah. How do you keep when you need your visa, please?
Yeah. I don't know if this was suggested to you when your kids were really young, but as you're introducing foods for the first time, you're not supposed to do like a whole bunch of stuff at once. So if they have some sort of reaction, you can kind of know what it is, So Anna's really big on that. So she does like one type of food every couple of days or something like that. But we did like not microdose, but almost we consistently gave Nathan peanut butter because I was like, I really don't want him to have a peanut butter allergy. So we're just kind of like, from the time he's really young, he's just going to get peanut butter consistently. So maybe if he was going to, hopefully he builds up a tolerance to it or something. I don't know if there's anything to that, but he does okay with peanut butter. So
yeah, I did the same thing with Jackson, and Jen was like, "What are you doing? You're not supposed to give him peanuts." I was like, "Babe, it's fine. I'm training him, okay?"
Yeah,
and then
we're getting his immune system ready.
As I'm doing it, I'm like, I don't know if I've actually looked up data on that.
We did have a provider suggest it, so it wasn't like I have not looked into it either, but I did have it at least suggested to me.
I'm pretty sure somebody on Instagram suggested it to me, so I was more just kind of winging it. But yeah,
maybe they didn't suggest the peanut butter thing. Maybe it was just the slow introduction of other foods. But so I have not independently verified whether that's the case. But it just makes a lot of sense, doesn't it?
Sure,
makes
does.
A lot of sense.
Yeah, and like you said, Jax eats peanut butter and likes it. So I guess look at that. We made
both
data.
My kids though, rashes to amoxicillin, both of them.
Unbelievable.
I know. So surely they'll grow out.
Do either of you have allergies to penicillins? No. Yeah.
One, they were very different reactions, but both very clearly had rashes to it. So I'll reintroduce it later.
Maybe they'll grow out of it.
Maybe they'll grow out of it. You want to do the password before we move on to cow's milk and dairy allergies?
Yeah, let's do that. So the password for today's episode is going to be IGE24. And IGE will be all capitals. I know it's not normally all capital letters, but for the sake of the password, it is this time. So nobody call us out on that. But IGE.
I thought it was always all capitals. Don't you always say that?
No, the middle G would be lowercase.
Oh, I see. Okay, I thought you meant our password in general.
No, our passwords are always capital. Yeah, that's why I
okay.
said I don't want to be like, oh, nice grammar, morons.
I see. You misspelled it.
Yeah,
okay.
I was taking that out of the YouTube comments. It's off the table now. You see that?
Can't do it.
That's called
we'll still get them though, because people.
Oh, for sure.
Will stop. They'll pause it right there, right when you say it. They'll pause it. They won't hear anything else.
But yeah, so go to freece.com's website and use that password to access the post-activity quiz. Have a blast. Get your credit. Good to go.
In case I talked over you, why don't you say the password one more time?
IGE24.
IGE24. All right. So moving on to cow's milk and dairy allergies. Allergic reactions to cow's milk proteins in adults is complicated by lactose intolerance, which is not an allergy, is an intolerance, which increases with age. However, a recent kind of large population-based survey, it was a phone survey to be fair, suggests that cow's milk allergy may be as common in adults as a peanut allergy, but less associated with severe reactions, and less frequently physician diagnosed. So since it doesn't, you're not typically going to see somebody carrying around a EpiPen because they have a cow's milk or dairy allergy. It's kind of less diagnosed and less associated with a severe allergy, and probably is more commonly called lactose intolerance, even if it is a little different than that.
Yeah. And so we've been talking obviously a lot about food allergies, but there's also a food-dependent exercise-induced anaphylaxis that can occur. So this is a form of food allergy in which the patient only develops symptoms when they ingest the culprit food and then follow that up within a few hours by, some kind of exertion or physical exercise. So we're not making a great case for eating fruits and vegetables or exercising in this podcast, but
a lot of the healthy foods happen to be allergy
terrible for you. That's what. Yeah, I'm telling you. This is opening my eyes to a lot, but symptoms do not develop if the food is eaten at rest or if the patient exercises without first eating the food. So there's the connection between those two, the food and then the exertion. May not be recognized for some time until it's kind of, a thorough history is taken and kind of put together. But in addition to that, the reactions are unpredictable, which obviously further complicates the recognition. Diagnosis definitely can be a very difficult concept, and because commercial skin tests, reagents, and in vitro testing may not be obviously reliable at detecting the underlying food allergy in this particular case, especially when the patient would need to, exert themselves after consuming it, would be very difficult to determine.
Yeah. There's also occupational food allergies. So allergies associated with your job. Most often develops in patients who work in food processing. Common causes would be fish and shellfish, but also wheat, other grains, fruits, and vegetables. So the culprits we've been talking about for people who process those things. They may present with respiratory allergy like asthma or allergic rhinitis, but also anaphylaxis or contact urticaria is possible. What's suggestive of it, obviously, is a history of the symptoms occurring predominantly in the work environment.
Yeah, that'd be unfortunate. You get a job and you're like, I love this job. I'm going to retire here. And then all of a sudden you're like, I'm so itchy.
Aren't we all allergic to our jobs, though?
Yeah, it's a good point. I think I'm allergic to the clinic, whatever we put on the floors here. I got to go home early every day.
I'm allergic to the phone.
Yeah, that's a good one. I can't answer patient calls, unfortunately. I'm going to need a person to do that for me.
I'm allergic to telephonic communication.
Yes,
I only text.
I only text patients. There's also this is something I actually knew someone who went through this. So this one is definitely can be life-changing for people, but delayed allergy to red meat. So this is a kind of an unusual form of an IgE-mediated food allergy, and it's caused by sensitization to the allergen galactose alpha-1,3 galactose, or alpha-gal, and which is present in tissues for most animals, with the exception of old world primates as well as humans. So, primates aren't usually consumed by most people, I would hope, but a lot of our more common animals that we do consume would have this present. And this form of meat allergy is distinguished by its delayed onset. So the symptoms appear 3 to 6 hours after ingestion, sometimes even happening like in the middle of the night if the meat was eaten for dinner. The symptoms are otherwise typical of an IgE-mediated reaction. So urticaria, angioedema can occur, even anaphylaxis, and sometimes can have gastrointestinal symptoms or even hypotension associated with it as well. The allergy, due to sensitization of this alpha-gal, is described in an increasing number of countries, including the United States, Australia, Spain, Germany, Japan, Sweden have all had cases of it. And patients actually become sensitized to alpha-gal through tick bites or exposure to the drug cetuximab, or the role of these factors there's a whole section again on Up to Date that discusses that, and so it kind of goes into much more detail. But I had a friend of mine that I hadn't seen in probably 2 years, and he was by no means overweight when I was knew him prior, but I hadn't seen him in 2 years, and I saw him again, and he looked like really skinny, like noticeably thinner. And I was like, I asked him, hey, man, have you been trying to lose weight? I didn't know if he was sick or what. And he had gotten bit by a tick and then developed this delayed allergy to red meat and ended up in the hospital out of nowhere. And so he basically had to become a vegetarian because he couldn't consume, I guess he didn't really like other forms of protein as much, and so he ended up basically becoming a vegetarian and couldn't eat any kind of red meat anymore.
Jeez.
And he'd lost so much weight because of that. But he'd gotten bit by a tick, and then all of a sudden couldn't eat red meat. Ended up in the hospital after eating a steak.
I tell you what, those ticks carry some nasty stuff, man.
Yeah, they're not great.
Like this whole Lyme thing, that has all these kind of extra symptoms that people don't understand and, question and things like that. Because I've known a couple people with Lyme disease, and, I don't know that much about it, but all I know is that these people, it was debilitating for them,
Yeah, for sure.
I don't know. I feel like we can just take out the ticks.
Is it that hard? That's why I never go on hikes, ever.
Is it that hard to take out the ticks? Like, let's just drop some from the sky and take them all out.
Yeah. I feel like we would also damage some other wildlife if we did that, but
maybe.
I don't know. I'm not a zoologist. What do I know? Or a tickologist, whatever
what
you
do
call
they
that.
do? What's that thing they do? Oh man, I'm not even going to say it because I don't fully understand it. But there's something that happens in the south of the America's southern border, or that area. Maybe it's in Nevada, where they drop some sort of organism, some sort of fly or something to prevent an invasive species from coming. They literally fly over and drop millions of these things. I will tell you what it actually is by the end of the podcast, but have you heard of that? You have not heard about
I'm
this
not
thing?
familiar with that at all.
Okay. We'll all be edified by the end. Just give me some time.
Okay. Make sure you focus on that for the rest of the episode, and I'll just take it from here.
That would be great, but I feel like they could do something like that for the ticks. I'm
Maybe
obviously
it's
joking. Maybe they eat ticks.
Maybe.
Something important to mention to patients that we've all kind of seen are those advisory labels that the food industry puts on a particular packaging when an allergen is not an intended ingredient of the food, but may contact or become part of the food, despite it being manufactured in a way that's accepted. So you might see terms like may contain nuts or whatever processed in a facility with XYZ, manufactured on shared equipment with blah, blah, blah. I didn't realize, but these terms are applied at the discretion of the manufacturer. So there's an accrediting body or FTC or whatever doesn't go in there and say oh, you got nuts over here, you got to put this on here. It's at their discretion. We advise, which is good that they do it, but I suppose there's plenty who don't.
Yeah, I was being sarcastic.
You'd
think there would be some kind of overseer of that, but
I would say that anybody who does it, because they're obviously by putting that on there's going to be people who don't buy the product because they're concerned about X or Y.
Yeah.
So because for instance, we advise patients who have a severe allergy to nuts to avoid something that says may contain nuts, because you don't know. There's no way to determine the actual risk or the serious reaction. So they're losing business by putting it on there, but I suppose they're also avoiding a lawsuit. So I'd say that for them, it's probably a net gain. You know what I mean?
Yeah. I'm sure at some point they did the math on it.
Yeah.
But also not just buying consumer products at a grocery store, but also thinking about eating in a restaurant. And so, if patients do have these food allergies of, whatever kind, making sure that the food that they're eating in a restaurant, doesn't have any kind of cross contact with the food that they're allergic to. Vanilla ice cream that was scooped with the same scooper that had contact with peanut, ice cream and peanut butter ice cream prior can definitely be a major problem. And so obviously patients are encouraged to kind of have good communication between the staff or the chef if it's a fancier restaurant or something. But trying to be very cautious of allergens that could be in sauces or in some kind of powdered form that the meal was prepared with, or some type of even like garnish on the plate or something that could be a problem, and then making sure that proper steps are taken to remove that potential allergen from the patient. So removing nuts from salads and whatnot. But depending on the severity of the allergy, really encouraging patients to be very cognizant when they go to a restaurant to not accidentally come into contact with whatever food they're allergic to.
Right. So let's talk lactose, because that's a pretty common thing to have problems with. It's a milk sugar derived from milk that is used in many dry powder inhalers, some brands of oral and injectable glucocorticoids, a few oral medications that are commonly used in atopic patients. Pharmaceutical grade lactose is considered to contain very little to no milk protein, on the order of a few parts per million. So less of a concern, but possible reactions in children with severe milk allergies have been reported, and small amounts of milk proteins have been detected in various dry powder inhaler devices, lactulose solution, and injectable methylprednisolone. So the preference would be lactose-free preparations or metered dose inhalers in this instance, which use liquid medications and propellants for patients who have asthma and a milk allergy. Also, when able, avoid other lactose-containing medications, the soluble tablet formulation of lansoprazole, for instance, chewable cetirizine, and the 10 milligram formulation of montelukast. In highly milk allergic patients for the same reason. This was always such a challenge when you would get this question, especially in the hustle and bustle of retail. That's like, my son has this obscure allergy or even a milk allergy. Does this like medication have anything in there that contains it? So it's nice that we have a few things that we know about, but in the moment you don't always know that off the top of your head, or you got to verify. So you're sitting there ripping open the ingredients in an active ingredients thing and reading through it and trying to figure out if any of these giant words could be concerning for whatever type of allergy they have. It always kind of put me behind.
Frantically reading so you don't look stupid.
It was all frantic. If it wasn't such a frantic environment, then you could find and verify the information. It's just to try to figure, and especially considering the fact that there are these ingredients in there, like there's lactose in certain formulations of things, so it's a reasonable thing to ask, but it's hard to find in like a very short amount of time, to be able to.
It's not a great environment for doing drug information research for sure.
Right.
I think we can all agree on that.
Severe anaphylactic allergy and active ingredient research. Yeah.
And not just medications too, but when it comes to patients with food, allergies, there's definitely a lot of cosmetics and things like that contain a variety of food-derived ingredients. There can be milk, nut oils, wheat, soy, those type of things that can be used in certain cosmetics. Children's crafts, like modeling dough, may contain things like wheat. Egg white is sometimes used to make smoother like finger paints, and chalk may contain casein. Shaved nut butter has been used in cosmetics and in baby care products, food, candy, those type of things. Do not appear to have residual proteins and should be safe, but always, read the label, be cautious if the allergy is severe enough.
Yeah.
Let's jump to talking about, since I'm just looked at the time, we're definitely getting close already. So let's talk about, if somebody does have, an anaphylactic reaction, some of the available options they have as far as treatment. Okay. You want to start off with the epinephrine auto-injectors?
Yeah. So there's a number of them, and, they've been in the news in the last few years for costs and things of that nature. But there's the branded EpiPen which contains 0.3 milligrams per dose. There's the branded EpiPen Junior Pen that is 0.15 milligrams of epinephrine per dose. And then there's authorized generics of each that are both of those doses. There's also generics of Adrenaclick, which was a different brand name that doesn't exist, but it's still going to be 0.3 milligrams for adults and 0.15 milligrams for children. There's also AviQ, which you see popping around some. And it
That's
has
the one with
also
the
has
audible directions, right? AviQ.
Yes.
I used to have a demo device of that, and it was pretty cool, but not very cost effective.
I wonder if they could have an AI version of that. But it provides audible instructions, like you said, and it has the 0.3 and 0.15 milligrams, also the 0.1 milligram dose. And there's various other types in other countries and things of that nature, but that's kind of what's generally available to the public. But of course, it also comes in vials for injection with a syringe and various other types of situations. But the generics are helping with the price, but it still does tend to be kind of pricey.
Yeah, and the pre-filled syringes, if a patient does go with that, need to be sealed properly, because epinephrine in an unsealed syringe degrades very rapidly, and that's not the time when you need epinephrine to realize that your product is degraded and is no longer effective. So making sure that you're getting it from obviously a reliable source, but definitely cost can be a factor. So patients will oftentimes be looking for a product that they can get at affordable, prices. Right. There is also a nasal spray now under the brand name Neffy that came out this year. It's approved for use in children and adults, and the weight limit is basically 30 kilograms and up. The device contains a single dose of 2 milligrams that is sprayed into one nostril. And if the symptoms do not improve, a second device can be used to administer a second dose to the same nostril starting 5 minutes after the first dose. And then the approval for that product was based on studies of patients that were not experiencing anaphylaxis, in which this intranasal dose resulted in equivalent blood levels as those obtained, with epinephrine autoinjectors. Studies have been conducted, though, with active upper respiratory tract symptoms and with nasal allergen challenge to basically suggest sufficient epinephrine exposure in those conditions. There is a concern, though, that with the nasal spray, that it may not be absorbed as intended in patients that have conditions that alter the integrity of the nasal mucosa. So patients with like nasal polyps, patients who have had nasal surgery, conditions like that have not been studied with regard to the pharmacokinetics of the nasal epinephrine. So making sure that, if you are going to go this route, that you get a good patient history before doing so.
Right. Before I talk about how many doses the patient should need, I should point out that what I was referencing is a real thing, and it's called the sterile insect technique. That it's applied in areas like Arizona and California, where for something like the pink ballworm or even the Mediterranean fruit fly, they will rear a large amount of these bugs and then sterilize them, usually through radiation, and then fly over and dump them all out so that they mate with the other flies and don't reproduce, and it prevents an invasive species. So that is what I was talking about. Yes.
Cool. I've never heard of that.
Yeah, I don't know why it was in the back of my brain. I couldn't recall what it was, but I figured it out.
It sounds like you were deep on a YouTube binge one night.
I was, and I didn't miss a beat on what we're talking about.
I went to the bowels of YouTube.
There is a consideration for how many doses a patient should have on hand. So, conventional wisdom would say like, well, they probably just need one EpiPen, right? Well, there's no guidelines or consensus about how many they should have, because one meta-analysis that included about 86 studies found that around 7.7% of anaphylaxis cases from any cause were treated with more than one dose of epinephrine. If you consider the reactions that were treated, subsequent doses were administered by healthcare professionals, it was 11% for food allergies and 17% for venom allergies. So you think, I really wouldn't want to be one of those 7 to 17% of patients. I would kind of like to have a second one on hand. which is reasonable. And so, I would say personally, why not? Why not might be insurance, concerns. Frequently, I think they'll, kind of pay for one in kind of like a month supply type of thing, even though the day supply is kind of strange with epinephrine or for EpiPens for that specific reason. But, it's not unreasonable to have a second one on hand. There's a theoretical concern that individuals who are overweight or obese may be underdosed, kind of considering on a per kilogram basis by the 0.3 milligram auto-injector, though that hasn't been proven, but it's something to consider. Also, the patient's distance from the nearest medical facility, if they're somewhere very rural, and if they wouldn't be able to easily have an additional dose administered by a healthcare professional in a reasonable amount of time, might be another thing to consider to have a second dose on hand.
And, the other thing to consider, the reason why some people may have some pushback as far as the number of pens they prescribe at a time or whatnot would be there are adverse effects, believe it or not, with giving epinephrine. And so there's some that are going to be more common, definitely, transient adverse effects. So, it's epinephrine. And so anxiety, palpitations, tremor, restlessness, dizziness, headache, those type of things. And again, those are usually transient and, what we would kind of expect. But there are some uncommon adverse effects and typically would be more likely to occur if a patient got too high of a dose. And these can be very serious. Ventricular arrhythmias, angina can cause a myocardial infarction, pulmonary edema, cranial hemorrhage, definitely, big spikes in blood pressure overall. So definitely things that would be very concerning and depending on the patient's, knowledge of their condition and how to use the EpiPen and whatnot, and who would be potentially treating them, you got to take those things into consideration, especially if patients are on, certain tricyclic antidepressants. Very rarely you'll see monoamine oxidase inhibitors, but that could be a situation as well. The patient who is, dealing with like cocaine use or abuse would be more likely to have some of those more uncommon adverse effects. And then also just obviously patients with pre-existing cardiovascular issues, central nervous system issues, thyroid diseases, untreated hyperthyroidism, things of that nature would definitely be more likely to have some of those serious reactions. And so that does need to be considered. It's not like a benign medication that you can just administer and, call it a day.
Correct. So as far as other therapies, food oral immunotherapy remains the most extensively studied approach for the treatment of food allergies. You'll see that office-based oral immunotherapy is increasingly used for a variety of foods, though there's concerns about that. There's limitations to that. We won't go too in depth on that, but just know that that's a thing. There was the first FDA-approved biologic drug for peanut oral immunotherapy in children 4 to 17 years old in January of 2020, with the indication of the mitigation of allergic reactions, including anaphylaxis that may occur with accidental exposure to peanut. So that was kind of a big deal. And the age limit decreased to 1 year in 2024, but there's no other commercial products for oral immunotherapy.
Yeah. Like Cole said, that's the one that's FDA approved. And basically, the immunotherapy powder contains consistent quantities of the major peanut proteins. In the clinical trials, the peanut OIT consistently increased the rate of allergic reactions, including anaphylaxis, which required treatment with epinephrine. And so this occurred despite the OIT increasing supervised food challenge thresholds, basically, inducing at least partial desensitization to peanuts in the clinical setting. It doesn't mean that basically the benefit of doing that and the patient being able to tolerate coming into contact with peanuts does not necessarily for every patient offset the risk of inducing an allergic reaction while being on the therapy. And so definitely something to consider and something that needs to be taken on a patient by patient, standpoint and not just something that can be given to any patient with a preventable or with a possible peanut allergy. But is available now, and like Cole said, this year it got the age did get decreased to being available to a patient 1 year old and older, up to 17. But yeah, so we're almost out of time, and so we want to touch on celiac disease just for briefly, because I know we were planning on doing that, but we'll have to be real quick about it because we'll get yelled at if we go over an hour.
Not too much to it, so I'll just highlight a couple of things. But celiac disease, which seems to be increasingly prevalent in the last decade or so, but it's an autoimmune disorder triggered by ingestion of gluten, which is a protein found in wheat, barley, and rye. The pathophysiology involves a few different stages. There's genetic predisposition, the gluten exposure, immune activation, then you get the autoimmune response, and ultimately you get intestinal damage. The immune system attack results in villus atrophy, crypt hyperplasia, increased intraepithelial lymphocytes, which compromise nutrient absorption, and the damage primarily occurs in the proximal small intestine but can be extended throughout. And so part of that is why you frequently will see other food intolerances in a patient with true celiac disease, because there's actual damage that occurs to the intestines and can affect the absorption of other foods. The symptoms of celiac disease: diarrhea, abdominal pain, malabsorption, various extraintestinal symptoms such as dermatitis, herpetiformis. The only effective treatment currently is a strict lifelong gluten-free diet. And this approach allows intestinal healing and alleviates symptoms. Obviously, there's increased cost to the patient associated with that because of the cost of gluten-free foods. There's psychosocial components related to stigmatization and social interactions, things like that. So all that is to be considered, though. I had a gluten-free chocolate cupcake yesterday. It was really good, and I didn't know it was gluten-free till afterwards. So I guess they're getting better at the taste piece. Yeah.
So there you go. If you're dealing with celiac disease, you got that option.
At least you got gluten-free.
It's verified by Cole. Hey, things are looking up.
It was tasty.
Yeah, so definitely avoiding wheat, rye, barley, but things like rice, corn, potatoes, the buckwheat, that type of thing is considered safe. And the other thing would be alcoholic beverages that have been distilled, as well as wine, are typically gluten-free. However, like beers, lagers, things like that, malt vinegars, those should be avoided because they are often made from gluten-containing grains and are not distilled. So, you got to be cautious with that. Oats should also be introduced into the diet with caution, because of a variety of oats with variable toxicity and uncertainty as to whether oats have been stripped of gluten. Contamination during the harvesting process is not always known. So definitely something to do with caution if you're introducing that into the diet. But can, like Cole said, greatly limit your options as far as food, and not all of the replacement foods are as tasty, unfortunately. But the other thing to consider would be, as far as the management goes, would be the repletion of nutritional deficiencies that could occur. So, testing patients for vitamin A, D, E deficiencies, vitamin B12 deficiency, things like copper, zinc, folic acid, ferritin, iron, things like that. Looking for checking like a prothrombin time for looking for potential like vitamin K deficiencies, thiamine, B6, magnesium. There's selenium. There's lots of things that we'd have to look at, depending on the patient's obviously disease severity and the dietary intake, or what they're limiting their diet to, and in making sure that we don't miss any type of nutritional deficiency that could be occurring because of that.
Right.
But yeah, so I think we're actually a few minutes over. So is there anything else we got to cover since we're out of time?
That's all I got.
We covered. We're told since this is a accredited episode we're not supposed to go over because we don't like to give extra credit. No, we got to keep it. We got to keep it on the time. People apparently, yeah. Some people complain for the extra 5 minutes of bonus material, but
right.
It's all good.
That's not like we have to listen to it. They already got the password. Yeah. We covered sterile insect technique, so I think that's the most important thing.
Yeah, that's true. That's a good point. So there you go. If you took nothing else away, make sure you do some additional research on that method. So again, thank you to Free CE for continuing to work with us, but make sure you go get your hour of continuing education credit for those of you who are members. And for those of you who want more, lecture style, I guess you'd say structured content, check out our Patreon, which has a variety of lectures, PowerPoint slides that you can download on all kinds of different topics, different disease states, and can be a good resource to review some of the pharmacotherapy involved with those various disease states. But patreon.com/coreconsultrx, you can sign up for either month to month or for a year at a time, and you get access to all of the lectures that are on there. There's probably 70 to 90 lectures on there, and PowerPoint slide sets that go along with them. So make sure you check that out. And check out freece.com if you still, after all this time, have not checked them out. They're a great resource to continue your education, and not just for credit, because you should want to, because you're going to be good clinicians and want to keep it up. But anything else for you, Cole, on your end?
Nope, that's all I got.
All right, that's all I got too. Thanks, everybody. Have a good one.